Thank you, Mr. Chairman. Members, this you have something in front of you I want you to look at. You have a pass out that we did. I've been out visiting a lot of facilities, and one of the things I heard when I visited folks is how many inspections are done and how much duplication there is. So we put together this chart, and it shows all the organizations that are inspecting these facilities. And then on the right, you can see how many times the same things are inspected. Now, what I don't want to do is to do something that is going to make for an unsafe condition in any of these facilities. But this applies not only to, well, this bill is about adult care homes, but this same problem's existing with our group homes and a lot of our facilities. So the whole idea of this bill is to say that if DHSR, which goes annually, annually, but every 2 years, the division is required to inspect adult care homes for compliance with physical plant and life safety requirements. County departments of social services are also required to do routine monitoring of adult care homes, but there's a whole bunch of other people that do too, and you can look at that. And what this bill says is if an adult care home passes an inspection conducted by the section within 3 months of a substantially similar inspection by other state or local department, agency, board, or commission, then the other state or local entity will be required to accept the section's inspection as if it was its own inspection and deem it as passed. And I did appropriate money to make this bill move ahead, but have been talking to the department about this. They do have some concerns. I've talked to folks from the health departments. I've talked to folks from fire. I've talked to a lot of organizations, and I think they're even surprised when we're inspecting for pest control 8 times by these organizations. I just think that we need to have a conversation. Now, I think that maybe in this bill, and I'm going to work with the department on some language because they have a little problem with some of the language in it. But we've got to get a handle on some of the things that we're putting these folks through. It'd be like if you had a restaurant and you got inspected every week. I mean, it's just too much. So I'd be happy to answer any questions.
Thank you, Senator Berger. Any questions from the committee? Senator Mayfield.
Thank you. I appreciate now what you're trying to do. I understand it better, but I still have a couple of questions. So this appears that you're really talking about sort of all these more, I don't know what to call them, things that are not related to patient or resident care. Is that right?
Yes, ma'am.
So,
Senator Berger. Thank you, Mr. Chairman. Yes, ma'am.
Okay. Follow up.
Senator, I'm going to recognize you for a series of questions.
Thank you. Okay. So, all right. So so this is not about quality of care. This is about the safety of the environment in which they're living and inspections related to that, right?
Senator Bergen.
Yes, ma'am. Okay. And it's really, I want to make sure that, because we've got to make sure that the safety of the residents at all of our facilities, that needs to be the number one priority. This is about repetitive, interruptive. They tell me it takes a lot of their people just to deal with not only the inspections, but also the paperwork and the follow-up, when they can have an inspection done and then the very next day have somebody else show up to do another inspection. And it doesn't happen every day, but I was at one facility and they were telling me they'd had an inspection and they were having another inspection, and the people were inspecting the same things. And part of the problem is you have people, and I've had this happen with health departments before, you have somebody inspects and they tell you to do one thing, you have a different inspector come the next time and they tell you to undo the thing that the other one told you to do. I've had that with building inspectors before. It doesn't happen a lot, but if you get different inspectors coming, they can counteract each other, and I think that's a real confusion too.
And one more. Do all of these agencies that you list here inspect these facilities every year, or so yeah?
Senator Berg.
It's different. Health departments in these facilities are supposed to do it every quarter, but DHSR depends on where you're at, and there could be 1 year, 2 years, and the department can probably correct me on some of these. I didn't go back and look. The local fire departments, it's supposed to be every year, but they don't always do it. It's just like one of my buildings where my office is in Anger. They're supposed to come every year. Well, I was looking, they haven't been in 2.5 years. So if you're from the fire department, I just telling them, you probably need to come and check my fire alarm systems and everything.
I guess that's the challenge is there might be what agencies are supposed to do, but then what they actually do. And you've got to have somebody who's sort of, holding if the fire department doesn't come and DHSR is there and they see something, you want them to be able to do something about it. So, anyway, all right, thank you.
Any further questions from the committee? All right. Sure. Co-Chair, Senator Gailey.
I just have a quick comment that I hate to think we're duplicating government services because we think that the first government service isn't there doing their job adequately, so we're going to add another layer onto that. I think that there's other ways to resolve that issue besides scheduling another entity to come and do the same work.
Thank you, Senator Gailey. I do have one person signed up. Before I do, any other comments from the committee? I have one person signed up to speak, Ben Popkin. Yeah, Ben, step to the podium. We'll give you 2 minutes.
Mr. Chairman, my name is Ben Popkin. I'm a volunteer with a nonprofit organization named Friends of Residents in Long-Term Care. We work statewide, and we work with residents and the families of residents in long-term care facilities, again, across our state. I wanted to thank you all, Senator Bergen, Senator Gailey, Senator Sawrey, for bringing this important issue before us. Because inspections, it pains me to hear of redundancy and inefficiency because it's such a vital element. The residents in our long-term care facilities, and in this case, we're talking about adult care homes, assisted living facilities. We also work with nursing homes as well, but it's vitally important that these residents who are paying to be there and paying for support services to make sure they get the best quality of life they can once their families or their home situation is not able to keep up with their needs, that these residents are well treated and that their home is safe, as all of our homes should be, that they get good or at least decent quality food and the services that allow them to live the life to the best of their abilities. So I wanted to thank you all for looking at this. Again, I would point out at this point, in North Carolina, long-term care homes have evolved over the years. We've moved from an era where they were often owned by community members. You may see the owner of a facility at your church while you're there, and everyone was working for the best of their community members in those facilities. We've shifted to a time where there's private equity companies increasingly taking ownership and seeing these as places where they can return a profit, which is their goal for their investors, but sometimes not necessarily keeping the best interests of these paying residents there. So I would point out that, again, the inspections are important, and of course, reducing redundancy and increasing efficiency is vitally important. But if there's anything we, as a voice for the residents and their families, can do to help give you information or be supportive in any way as you look at this issue, we would love to do so. So thank you again for the attention. I appreciate this focus on this population and look forward to your work on this in the future. Thank you.
Thank you, Mr. Popkin. Any further comments from the committee? Senator Mayfield, comment or question?
Suggestion.
I will hear a suggestion.
Okay. So it does seem like, I think I understand what you're trying to do. This also seems very broad. I wonder if this could be, if this is a good subject for either a study committee or a joint legislative oversight committee or some entity that is going to actually look at it and be really thoughtful about it, rather than us just changing this law or putting this in place.
I will hear your suggestion, and I think it's one of the 3 primary sponsors. Glad to talk to you. Senator Bergen, comments?
This bill does what a lot of the bills that we do up here. It gets people talking. So I assure you that there's going to be more conversations, and I doubt that it will be in the exact same form when it is adopted.
Thank you. Do I see a motion? I see a motion for Senator High, second by Senator Moffitt. Does a motion for a favorable report for the bill with the referral to appropriations. All in favor, please signify by saying aye. Any opposed? Likewise, the ayes have it. Motion carries. Thank you.
Thank you. The chair will recognize Co-Chair Sari. Oh, and Senator Michael Lee.
Thank you, Mr. Chairman. So a lot of you are wondering why you see someone who does a lot of ed work standing before you in the healthcare committee, since I used to be on the healthcare committee and they fired me from the committee. So I figured this was my only way to get back here, was to file a bill. You know, seriously, when I joined the General Assembly back in 2014, and some of y'all were here back then, and there was not a Senate budget without a CON full repeal in it. It usually came and dropped in a budget and wasn't necessarily brought through a committee. And over time, you might have seen that happen through the years. We would file the budget and you'd hear a big explosion and there'd be a lot of people talking and arguing. And CON obviously has been one of those issues that have been going on in the General Assembly for quite some time. When I first got here in 2014, I went to my local hospital and they talked to me about how they built their business model around CON and how that was how they provided charity care and went through kind of all that history. And of course I was doing all the research back then and advocating and was really concerned about the repeal, to be honest with you, because they would say, well, you know, it's not really a free market. And I've heard all the arguments for a really, really long time. And what never really came, I mean, all the technical arguments we talk about, all, you know, providers and payers and everybody else. But when it comes right down to it, my family is actually a relatively healthy consumer of healthcare. So we're very familiar with a lot of these issues from just a consumer perspective. But a lot of the issues really come down to the patient. And so in ed, we always talk about the student, the child. And all these other things are going on. And sometimes the patient access, affordability, sometimes gets a little lost. And I realize that there have been in the past a need for CON. I realized the federal backdrop in the 70s. I realized when I was graduating from high school in '86 that the federal government repealed all of that. And so this has been going on a really, really long time. I acknowledge the work that the General Assembly has done and industry has done back in 23, where we repealed some CON and we modified the ASCs. But now is really the time to keep moving forward. This is a pretty narrow bill in what it provides. And I've gotten some emails and maybe a few phone calls of folks who weren't real happy about it. And since we've been talking about this for so many years, I mean, everyone's read the bill. It essentially repeals CON for the ambulatory surgical centers and the rehab facilities, services and beds, and make some of those conforming changes. But so it's a pretty simple bill on its face, but I know that the issues surrounding it can get really complicated. The last part of this bill provides some planning. I mean, with the Singleton case and all the other things that are going on, we need to do some planning. I know that there are a lot of folks, Senator Sari in particular, that has talked about the planning that's necessary, so we don't just get a Supreme Court case and it ends up being like that Senate budget that just, you know, repeals it in a day. And so that was really why I'm here. Because we need to find a way to move forward in the area of healthcare. There are a lot of other things going on, site-neutral fees and all the other stuff that's being worked on. This is one piece of that puzzle that we've got to move forward to help patients and consumers and constituents on the healthcare front for access and affordability. One small piece of what's part of a broader group of legislation that you see moving forward. And so I would really appreciate your support. I have technical support, who's the expert on the Singleton case and everything else, CON. And I know there are a lot of other people in here, experts, the chairs, Senator Heiss and others who've dealt with this for a number of years as well. So I would appreciate your support. I think there's an amendment to fix a technical glitch as well.
Sir, sorry, do you want to send forth the amendment?
Yeah, I'll send forth the amendment. The amendment, just very briefly, what it does is, so Senate Bill 316 included a similar repeal of inpatient rehabilitation, rehabilitation facilities, use the CMS definition. We're just carrying that definition over from Senate Bill 316 to this particular bill to make it consistent with the two.
Okay.
Glad to answer any questions, but I would describe it truly, as Danny Britt says, as technical in nature.
So that comes as a motion from Senator Sari. Any discussion about it? All in favor say aye.
Aye.
Any opposed? The ayes have it. Would you like to go ahead and speak to the bill also?
Just a few comments. I think this committee has heard ad nauseum from me last session about CON. I could spend another 30 minutes talking about it. But why I think this particular target on ambulatory surgery centers and inpatient rehab facilities is important is, a couple reasons. I'll talk about the ASCs first. So if you recall, in House Bill 696, there's a direction in there for the Department of Health and Human Services to look at site-neutral payments, which means moving procedures from hospital inpatient settings to ASCs. If we want to talk about costs and talk about saving dollars, this is a meaningful step that we can do to actually make that happen. The data is there, and this morning, just quickly, anybody can do it. You can go on your phone and look it up. You can pull a study. 2024, the American Academy of Orthopedic Surgeons found that considering all CPT codes together, procedures performed at ASCs resulted in approximately 35% savings of total cost, 41% savings in facilities fees, 36% savings in Medicare payments, and 28% savings in patient payments compared with hospital, outpatient, or inpatient settings. That's significant. So as we continue to talk about billion-dollar rebases, and the largest line item in increase in rebase is, or one of the top 2 or 3 is hospital procedures. This is real dollars to the state. So when we talk about state employee raises, SCIF dollars, infrastructure funding, and keeping the tax rate low, this is something meaningful that we can do to save taxpayer dollars, to drive down health insurance premiums. There is no sensible reason whatsoever to continue holding off on repealing CON for ambulatory surgery centers, with the exception of some things that I don't really begin to understand or fathom. This is a step that's in line with something we've already done and directed. I think is particularly timely in light of the consolidation we're seeing in the Wake County market, with that risk of what that's going to do to our health insurance costs. Treasurer Briner is leading that charge and talking about what that's going to do to our state health plan, what that's going to do to the overall Wake County market. Again, this is targeted, it's precise, it's something that we can do to help the broader region with ASCs, and it saves dollars. With IRFs, with inpatient rehab facilities, this is about patient access and getting people the care they need, which there's some irony in that because some of the justification for CON initially. There's a podcast, maybe listen to it, that talked about a study from the transitions to care. It was done last year. But sometime last year, there were 360 patients waiting for a transition from a hospital to another setting because there was no post-acute care destination that was available at the time. Now, not all 360 of those people would go to an IRF. Some would go to some other facility or something like that. But again, it's not as simple as you go to one place. Different people or patients have different acuity levels. They might need something in a different setting. They're being moved to places that are far from their home and far from their families because we don't have a robust enough network. Now, the people who are proponents of keeping the CO in place will talk about that we have a 66 or 67% occupancy. But if you look and ask the question, why do we have that occupancy level? You actually drill down and see, well, maybe it's because patient choice. They don't want to be double bunked in a room with their level of acuity. Maybe it's because they're far away from their house. Maybe it's just because there's staffing or workforce issues that are there. So let the market take care of that. Let the people that are building these facilities, the hospitals, the standalone companies, the folks that want to come and provide this patient access and care, they can make the determination. They're not going to make a 9-figure investment, make the commitment to resources without having the need for the patient care in place. We can do this. We have people that are currently sitting in these hospitals, and it's costing the state money, it's costing the health plans money, and it's taking up hospital beds. So in that same podcast talking about the transitions to care study, the excess days for North Carolina Medicaid patients In acute care hospitals, it's between 80 and 150 days. That's more time, that's more cost billed to the state, that's time away with their families in a place they don't really need to be, but they could be in something more appropriate, like an inpatient rehab facility. Again, other states have done this. It's not hard. We just need to have the political courage and the will to make it happen. And I think we can do it. And maybe I'll be back here again talking about next year, and I probably will. But at the same time, if we don't keep the pressure up and keep the conversation going, I think we're doing a disservice to patients, taxpayers, and people all across the state of North Carolina. And I will repeat one last time, and you'll hear it again on the Senate floor probably. We have an opportunity to take a look at what the North Carolina healthcare marketplace will look like, potentially in a post-Singleton world in case the Supreme Court deems this unconstitutional. If we do not plan and we do not think about this, it could be chaos. We need to take those proactive steps. We have a chance to do it now. So I will extend the invitation again to any of the stakeholders who want to have that conversation. Let's have that conversation. Let's have it today. Let's not do it at some point in the future. And the conversation does not need to be, no, we just don't like what you're talking about. We want to keep CON in place. I don't want to hear that conversation. If you want to have it, let's have a productive discussion about how we can shape this and what it looks like going forward. We can do it for the taxpayers, the state of North Carolina, for patient care and access. It's a win-win-win for everybody. I think it makes common sense, but I've learned sometimes that's in short supply here. Appreciate the opportunity. Glad to answer any questions.
Senator Lee, any final comments before we open it up for questions?
Go team.
There you go. Senator House, I was going to call on you even before you raised your hand because I knew you would want to talk about this. So go right ahead.
Thank you, Mr. Chairman. I guess comment that I want to make. I do want to point out that the bill also directs the Department of Health and Human Services to develop a plan for eliminating all CONs within the state. Probably to no one's surprise, I am more a day one philosophy when it comes to CON. It's an unconstitutional practice. It's an unconstitutional practice of the state. And I think it's time for the courts to strike it down completely and not let us continue. That's generally how we deal with unconstitutional things. We don't take a 3-year plan to phase them out. But I say in those for ambulatory surgical centers is the, peak of the mountain because those tend to be very profitable for a lot of centers and others. But we've got healthcare shortages. Western North Carolina is probably designed around healthcare shortages. Even having a small rural hospital in my community, it means that perception is most of the visits there are to load up in a new ambulance or a helicopter to take the additional hour drive to get to Asheville. You can imagine being in Asheville and trying to discharge a patient that leaves an hour and 15 minutes away and try to set up services and others that they need. The funny thing is there are 2 additional hospitals in the same service region that are doing everything they can right now to be able to build. But the wonderful committee that makes these decisions decided that the current facility should be the one to receive the additional beds and didn't do anything to change our travel times for others. And I was on that committee many years ago, but apparently now it's a staff decision and not even a decision of the committee. But the entire process is a real problem. If facilities want to build in Western North Carolina, the answer should be yes. That's what coming in. And if you think you have the capacity to build a 150-bed facility and you're taking that risk, have at it. That's what coming in. If you don't get the return on it, that's your problem. You chose to build as a facility. So this is a real impediment to health care, particularly in Western North Carolina, but I think all over the state. I would say to everyone involved in this, obviously this is a small step to where we've been before and kind of a progress, and there is a plan coming out of this, but the day is coming. And I hope it's with this court case and where they find, but I'm really going to say that this is an opportunity to get involved and to plan the end of the CON process, or the axe is going to be much more not your desired outcome. So, appreciate you.
Thank you, sir. Other questions?
Mr. Chairman, I have one more last comment if there's no other questions.
Senator Gailey has a question.
Actually, it's just a comment. In doing my research on CON, I think I can't remember which of my fellow senators mentioned that it arose during the 1970s when there was a healthy appetite for price controls. And there, during those years, the Soviet Union loomed large, and there was an appetite in certain corners of the U.S. economy to adopt some Soviet-style practices. That's what CON is. It's a Soviet-style practice of controlling supply. And as the Soviet Union has fallen, I think CON should fall. We should tear down that wall.
Senator Lee.
Not sure how to follow that.
Tear down something else.
I just wanted to say one final thing. It's going to dovetail on kind of how we started. We've been doing this, working on this for quite some time. I do think we're finally kind of getting to the short rows on it all. Senator Sari made a really substantial offer. I know he's made it before. I'm hopeful that folks will move forward and take it up. For those who are really opposed to this bill, I mean, the idea was to, I mean, this is an appropriations bill. The idea was to move this bill forward into committee so that we could continue to have those discussions, and so that we can continue to make the offer to be at the table to help move the ball down the field to increase access, affordability, and transparency to residents, and increase care in a lot of those areas where we just don't have it. So thank you, Mr. Chairman. Thank you, committee.
Thank you. Any other questions from the committee? I know I have one person that signed up to speak, Jason Melber. I think I got that right. Jason, would you come up, and I think you had some comments you wanted to make.
Good morning, Senators. My name is Jason Melber, and I am the Coalition's Manager at Americans for Prosperity, North Carolina, and I'm here to ask for your support of Senate Bill 1040. North Carolina has more healthcare facilities and services regulated under its CON laws than 49 other states, for a total of about 27 Certificate of Need requirements. Furthermore, the Americans for Prosperity Foundation found that between 2012 and 2025, $4.2 billion in healthcare investment was denied by the North Carolina Department of Health and Human Services through the state's CON laws. As North Carolina's population booms, more than double the amount of healthcare investment has been denied in the last 3 years than was denied in the previous decade. Repealing Certificate of Need requirements for ambulatory surgical centers and inpatient rehabilitation centers equals less regulation, which means an increase in access, affordability, and freedom of choice for North Carolinians when it comes to their health care. It is for these reasons that we ask for your support on Senate Bill 1040. Thank you.
Thank you. And I will just remind everyone that North Carolina has some of the most expensive health care in the country, so all of these things need to be discussed. Is there a motion? I have a motion from Senator Heiss. Senator Heiss, may I read this motion for you? A motion for a favorable report for the bill as amended, rolled into a new PCS, unfavorable to the original, with referral to appropriations. Does that sound okay, sir? We have a motion. Any discussion about that motion? All in favor say aye.
Aye.
Any opposed? Ayes have it. I think we're through. We are adjourned.